always learn something.
Okay, thank you all for coming back to what I think is going to be a very exciting and very timely next section. My name is Joe Selby, and I'm the Executive Director of the Patient-Centered Outcomes Research Institute. And as many of you know, we're on record as saying that we aim to provide the kind of evidence that can allow patients and their clinicians to make decisions about which of two or more treatment options are best for them. So and to provide trustworthy information. So trustworthy to me suggests good, precise, as well as valid information. And for them suggests that we have indeed looked at notions of treatment heterogeneity and zeroed in on subpopulations to see what works better in subpopulations. So we're certainly excited about the notion of larger, or at least large enough trials. And a reflection of that excitement is the fact that there are 4 PCORI scientists in the audience today, and when you consider that the scientific staff of PCORI is 8, that's dramatic. No other funding agency here today can say that, I bet. So I think we're going to start a session now that may begin to upset the apple cart just a little bit more. Things have been going pretty well this afternoon. There's been a lot of agreement, as Michael Lauer pointed out. Folks from academia, funders, and industry do tend to have a pretty high level of agreement that larger trials and simpler trials would make a lot of sense, and more of them too. But there are other players in this enterprise, particularly if we begin talking about conducting these trials within systems, if we begin talking about learning healthcare systems. So the title of this section could be, what's it going to take? What's it going to take to bring the other players more uniformly, more enthusiastically, more supportively to the table? Another way of saying it, I think, that we've come to think is important is, what's in it for me? It's pretty clear what's in it at this point for the research community, for industry, and for funders. We haven't even begun to make the case really of what is in it for patients, what's in it for busy clinicians and the healthcare systems that they work in, and what's in it for payers. So we have panelists representing each of those 3 sectors, and I'll introduce them in just a minute. Just one last thing to say in kicking it off, and that is that large is good, but high rates of participation are much better. Large and high rates of participation. As Ralph showed us this morning, earlier this afternoon, at least he pointed to the specter of treatment heterogeneity precisely hinging on whether patients opted to participate in the trial or not. And so that's a fear, and particularly when, for us who are trying to provide trustworthy information and say, yes, indeed, ma'am, this applies to you, we'd like data from trials with high participation rates. So without further ado, each of our panelists is going to speak for 10 minutes, and we hope we'll have right at 30 minutes for questions and answers. There should be a lot. Our first presenter is Nancy Roach. Nancy is the chair of the board of directors of Fight Colorectal Cancer. You heard from her just a minute ago with her comment about informed consent and waiving informed consent. She founded Fight Colorectal Cancer in 2005 after her mother-in-law was diagnosed with colorectal cancer. She's also on the National Cancer Institute's Board of Scientific Counselors and the Clinical Trial and Translational Research Advisory Committee. Next, representing physicians and healthcare delivery systems is Dr. Alan Goh. Alan is Chief of Cardiovascular and Metabolic Conditions Section at the Division of Research in Kaiser Permanente, Northern California. And maybe even a little bit more to the point now, he runs a unit called the Comprehensive Clinical Research Unit and is a Regional Medical Director in Northern California, Kaiser Permanente, for clinical trials, which means that in fact I know that he's been spending much of the last 7 or 8 years trying to get large trials up and running with high participation rates and high numbers of participants in a large healthcare delivery system. And third, Lou Sandy represents the payer community, and Lou is Vice President for Clinical Advancement, United Health Group. And he focuses there on, in fact, clinical innovation as well as payment delivery reforms. Before joining United Health, Lou was Executive Vice President of the Robert Wood Johnson Foundation. So all three of our presenters, I think, are very well versed in the importance of clinical trials, and each brings a unique perspective. And we'll start with Nancy.
So thank you for the invitation. Can you all hear me? Okay. Joe sent out an email over the weekend that was terrifying because he said, when the light starts flashing, I'm dragging you off. So, and we don't want to hear about what you've been doing. We want to hear about the reality of your situation and what you think. So I took that seriously. I have 4 slides. And how many people here have watched 24, the TV show? Right? And you know when Jack, he gets on the phone to Chloe and he says, download the PDA, download to my PDA the architectural scheme of the building that I'm trying to break into. And we all go, oh yeah, that's real, that's real. And I think patients look at the research system kind of like that. We think it's 24. We don't realize it's kind of like Bonanza. You know, it's very different. The reality of clinical and research in clinical care and research here is very different than I think what most of us think. So what is the biggest challenge and how do we change that? And I am not a Jack Bauer, so did that work? I think that's the biggest challenge, right? Think about it. You're on the table, you're naked. You're there because you're sick or because you have routine maintenance coming up. And your doctor wants to talk to you about a clinical trial, and you're going, wait a minute, I am so not there. You know, and so how do you change that equation so that people do care and they're willing to listen? And so here's my solution. And Mike, you said this. You know, we're partners and consumers of research. We're not human subjects. And I say this frequently, and I get a lot of very strange reactions, especially from IRB people. They're like, can you say participants instead of partners? Like, okay, yeah, whatever, but it's clear, you know, we're not lab rats. So if you think about us as consumers of research, it puts a very different picture in how you develop the research because you want to check with patients before you start. Is this a question that's important to you? Because if you can't make that case before you start, you're kind of doomed to failure. Decision-making support. So my washing machine is in the process of dying slowly and painfully. I need to buy a new washing machine. What do? I ask my friends what they have, and I read consumer reports. When you look at this person, you're asking them to make a decision in that situation, not knowing what kind of information they need. So there's a real reality check of what do you need to make a good decision? What time do you need? How do you do that in a way that makes a compelling case for research? Because patients do believe in research. And then post-purchase updates. Once you're on a list, once you fill out a warranty card, you're there for life. And there aren't enough trials that connect back with the people who are on the trials. I've seen some great examples of trials that do newsletters and things like that, and patients love them. My dad is on the prostate, lung, ovarian, colon trial that NCI is doing. Every time he gets a newsletter, he emails me. He's excited. I'm doing my bit for humanity. And why does all that matter? You want to create satisfied customers because satisfied customers are your champions in the community. And they will go out and they will tell people about the trial and they'll say, hey, I'm doing this. It's very cool. I'm helping other people. Why don't you think about that? And there are situations, NCI did a training about 15 years ago where they went out into communities and talked to community leaders and told them how to talk about clinical trials. And people went out and talked about clinical trials. And all of a sudden, NCI had to stop doing that. And I heard kind of behind the scenes that they had to stop doing it because there was so much demand for clinical trials that didn't exist that it was creating strife in the local research institutes, which I thought was fascinating because I like the concept. You know, in my heart of hearts, I want every doctor's visit to be a clinical trial. I would much rather do it that way than the way I currently do it, which is I go in and, well, sit on the table and all that. And so this is one of my favorite quotes. Talk doesn't cook rice. I'm looking forward to the next presentations and to the discussions tomorrow because I've been doing this now for, oh gosh, almost 20 years. And I've been to a lot of meetings about the same topics over and over again. And this is one that I would really like to see some change. And I'm done.
That was remarkable. You managed to say some very profound and provocative things in your 5 minutes, and maybe we will just take advantage. Go ahead and have Alan and Lou present, and then we're just going to have a nice, generous amount of time for conversation.
Great, thank you, Joe, and the chance to come and talk to you to provide at least my perspective on SIMP trials in the health system and clinicians. And so I don't have that many more slides than Nancy did, but I'm going to try to cover just briefly these topics. One, looking at trials in the context of health systems and what they're dealing with now, the reality of competing priorities, and I'll give you my take on the EMR and to some degree why I think it's a bit of an illusion that it's the ultimate or just the simple solution. But more positively, why should health systems and clinicians be active participants in trials, particularly large trials? And then talk about whether we can find those win-win-win-win, not just three, but including all the stakeholders in, and some suggestions that I hope will kick off our conversation about where we go next. So just in terms of putting in trials, we all know that there's been a tremendous amount of discussion around the Affordable Care Act. We know certain things about it, but there's a lot of uncertainty. And as many people know who work in health systems or with health systems, there's a lot of angst about that. There's a lot of churn because we don't know how it's all going to play out. And so because of that, we do know a few things. One is that every health system, and I'm sure as Lou will talk about, is in the era of declining revenues, or at least challenged revenues, and increasing competition as everyone is trying to get more efficient, everyone is trying to get more productive, and the reality is the ACA is creating, in essence, for every health system, a larger fraction of older, sicker patients, and also requiring a lot of folks who have morbidities that were never treated because they didn't have health insurance. Maybe a good national thing, but from a health system perspective, it raises some new challenges. Now, if you take a look at some of the leading healthcare delivery systems, many of them were already ahead of the game. They actually have already spent a long time trying to figure out how to become more efficient, how to become more effective, how to drive quality of care. And now, through doing that, there's not a lot of extra margin to add on more work, even if that work has a lot of value morally or for other altruistic reasons. So we have to think about that in the context of introducing the concept that they should be active participants in clinical trials. The other aspect, and this has been touched on in different ways, is that it's very clear as you look across different stakeholders that their goals are not always the same. The healthcare delivery system versus the researchers who propose research. I'm a researcher, so I know that happens with my own system. The sponsors of research and as patients are often different. They're often conflicting, and so we have the challenge of trying to find out those spots where they really aren't. So what are some of these competing priorities that every health system now has to deal with? One is we all want to optimize quality of care. That's one of our goals. Secondly, we want to improve patient access as part of that. And very highly related is increase the efficiency of our providers. The EMR, EHR has helped, but it's also added to the burden. It's both part of the solution and part of the problem. But these are three major areas. If you talk to anyone in the healthcare delivery side, these are major things we're going to need to do. Now, part of that, both for a variety of reasons, is we need to implement and enhance our EMRs or EHRs. And that comes at a major cost to everyone. Because in all of that, as a business, a healthcare delivery system needs to maintain its revenues and is all the time thinking about strategic investments to help accomplish all the other goals. So we're now trying to introduce the concept of we want to actively get participation in a trial while you're all doing all these things. It can be done, I believe, but I think these are some of the challenges, the priorities we have to face, and how do we make the persuasive argument to do that. And then my take, it's my own personal view of the EMR. I've been working with it for a really long time. Is it really a simple solution? I think it's part of the solution. As many people know, Kaiser Permanente, it's in 7 regions of the country. I'm in Northern California. Collectively, one of the largest and most complex inpatient, outpatient EMRs that exist in the country. It is based on Epic, but that's sort of saying like this is a hamburger, right? Because hamburgers are all made of meat or generally, but they're all different. So is it the simple solution for trials? I think it does have a lot of advantages. We know that. We know that there are a lot of efficiencies versus when I started 15 years ago, only paper medical records existed. It was very painful. A lot of things you can do electronically on the back and the front end. But we ought to be real clear about some of the problems. And that is, it's really true that even if it carries the Epic name or any of the others, it is all different no matter where you go. So that's a real problem. It is a common platform, but it's very, very different. And any health system that is active about it is constantly changing it. So one of the things I mentioned to one of my colleagues here is that when I've approached the head of our EMR and I said, hey, I really want to introduce something to improve something with a research study, he says, I have 200 top priorities. I said, okay. I said, how do I get to 201? He says, you never get to 201. You never get to 201 because that 200 is really a 200 on a list of 2,000. So we have these clinical and operational priorities, and you need to make a very persuasive argument for why your work needs to get ahead of everyone else's. So I think this is a challenge. It's not, you can do it, but I think it's a big challenge we need just to be aware of. And I think they're very serious about it. Now, I know this comes out for many of the people who have done trials in the past, but the concern raised by Dr. Lauer, which is how valuable are the data in an EMR? Is it really garbage in and garbage out? Well, sure, there are definitely some data that are not very clean. But I think we have ways to try to get at that. And I think ways we have to try to be very proactive in convincing healthcare delivery system providers to do a better job and how we can do things that have dual purposes. But the other more daunting aspect, which I've worked on, is if in our Epic at least, there's 47,000 data tables on the back end. So we have to figure out better ways of getting at that data. We actually have the fortune in Kaiser Permanente, we don't have to go get consent every single time. We have a blanket consent for us to use that, but it's still very daunting when you're trying to find a variable that you see on your screen as a provider. How do you find the data on the back end that can be used, for example, for clinical trials? So one of the things I think that is very challenging too is that when you're trying to get standardized data collection, it's not ingrained in the culture of providers. Even when we have smart sets, which I think Dr. Barr spoke about, it's great, but if anyone's ever filled them out, there are ways around them. There's always ways around them if you're clever as a provider. So we have to think about the challenge of the workflow for providers, the alert fatigue, not just that, but just the idea of standardized data collection. And what I think really is, how do you serve dual purposes so that the person's motivated, to do it right? And then I do think that there are times that the EMR is useful, but not always. And so I think it's part of a solution for certain kinds of questions, but not for every question. And I think that we have to be very creative about how to use the EMR, both for data collection, randomization, other reasons. But I think we should not assume that's the only answer. So let me move quickly on to why I think that health systems and clinicians really should be participating more actively in trials. And as Joe said, I've been spending the last several years trying to examine within one region of Kaiser Permanente with 22 medical centers, how do we do that? How do we try to get people to get on board? Well, one is it's very clear in conversations with leaders on both the health plan and the medical group side, there are pressing questions that need to be answered. And they come up all the time. And it doesn't just around quality. There are just a lot of things we don't know in medicine. And it's, I think, a ripe opportunity, if we can craft it right, to show that randomization, in fact, is a very important design, and that the culture of randomization needs to become an advantage to a healthcare delivery system. Not just something that you'll do if you happen to like the person who approaches you, but actually something that's really, really pivotal to helping the health system. And I don't think it's the only answer, but it's complementary to the observational and other methods we have. So developing this idea of a culture of randomization, similar to what Dr. Lauer mentioned around a patient having an expectation that when they come to any healthcare delivery system, that being part of research is really an added value, that we need to really capitalize on that and create some, again, some very persuasive arguments. And that the health systems gain from that, and either reputationally or otherwise, that we can do that. And I think we want to think beyond just quality improvement, because I think as Dr. Chowdhury mentioned, that's a great way, but I think we should think beyond that too and see if we can extend that model. It may not always work for a placebo-controlled trial or even a device trial, but we should not assume that it can't. And I think we want to make arguments for how you can do this and test cost-effective strategies, for example, which help to fit within those priorities. So obviously the idea is that we have at least 4 major stakeholders in this game, some of them represented on the panel, some on the prior panels. So where do we find these win, all 4? And it's deliberate. There's not always the easy sort of intersection of all of those 4 in this Venn diagram, but I think it's a critical thing. So where do I think we might try to go next? I think it's a challenging climb, but the reason I think we're all here is because we believe that it's worth doing and that we want to figure out how to accelerate that climb to the top. So one, I think from a sponsor perspective, I think one of the issues is to really try to get systematic input in the design early on before a research project is funded. I think that doesn't happen very often. I get a call about once a week from someone who said, congratulate me, I just got a trial funded by NIH. And we don't know how we're going to do it because we just got cut 25%. But I'm coming to you at Kaiser Permanente, and you really should help us. You really should, because it's a great idea. And I'm not really jesting too much about this. It is a common thing, as if there's some moral imperative. But I think we need to kind of think about this ahead of time and, again, involve those priorities in the way we set this as research sponsors to really think about what we can do and to work with researchers, not oppose them, to work with them to figure out how to make those questions even more relevant. I think the other part is it is not just about throwing money at systems. In fact, I think that alone wouldn't work at all. I think it's about getting proper compensation and trying, again, to fit it into the goals of that health system, particularly that ones that are already efficient. And then just two last points. One is how do we find ways to really incentivize the healthcare delivery system to be part of that solution? I think reputational gains are definitely part of that. And we've seen some very excellent institutions that have really leveraged that approach with their members and with the community. Again, overlapping priorities and trying to find out where they meet. And then I think the hard part in the next day or so is how do you actually begin to line up the criteria so that it really makes sense for healthcare delivery systems to be active participants. The whole idea, the questions, the timelines, the designs, most timelines for R01s, as we know, takes 18 months or so when systems need questions in the next 6. Consent requirements, I think, really need to be looked at. I would agree with Dr. Devereaux's comments that they're not always yes or no. We need to be very clever and creative. And also the data collection, I think you can do certain things passively, other things you may need to do more proactively. So finally, there are many different kinds of consortium or groupings, and I think we ought to challenge ourselves in the healthcare delivery system is, should we really think about that? About grouping together a consortium where we all, as systems, have skin in the game. And in doing so, that we all also balance the risk, we also balance the rewards. And how would that happen? But I'd put that out there as a possibility and try to get the major systems to get on board. And so I'll end just with a few things that, at least in my institution and in other regions of Kaiser Permanente, that are potential examples of things that could have gone the way of randomized trials that were of interest to the stakeholders, at least internally. One is that what's the proper workup for hematuria? You'll be not surprised to know there are really no good randomized trials for this, to screening for certain kinds of cancer. What do you do? But you can imagine a trial that integrates decision support. Surgical versus catheter-based therapies for cardiac valvular disease. Yes, there have been some trials, but again, the highly selected nature of those patients, are they generalizable? Why not try to do a large, simple trial when we're thinking about rolling out the therapies? We have many different ways on the risk stratification side. Can we test them again in a randomized way for risk for stroke, bleeding, for AFib, and deciding which anticoagulant to use? And finally, as was mentioned, I think, by Bob Temple, about back pain, right? Common, major resource, but we don't do the trials to figure out which ways to most effectively figure out what to do for the right patient. So let me end there and look forward to the discussion. Thank you.
Well, thank you for that emotional roller coaster of a presentation. I was getting very depressed halfway through it, Alan, but you really, you pulled it out in the last 5 minutes. Thanks. And now we turn to Lou Sandy from United Health. Thanks, Lou.
Well, thanks and good afternoon. I appreciate being here. It's been a fascinating, very interesting symposium so far. I'm going to talk about the payer perspective, and there'll be a lot of overlap, I think, from what this panel has already talked about, because as a payer, we really do think we represent the interests of the stakeholders that we work with both the delivery system and plan sponsors and the consumers that we serve. I'm going to start very broad and then trying to hone in on the issue of LSTs. I think one of the first things you have to understand from a payer point of view is that what we cover is a contractual relationship that we have both with a plan sponsor and a member. And as part of that contract, there's a term called covered service. And that has a specific meaning and definition. And it basically means it can't be typically investigational or experimental. So one of the things that we have to do with medical policy is to take the literature and try and determine when is something eligible for coverage and not investigational or experimental. To do that, we use a defined structured review process with an explicit hierarchy of evidence. And I'm talking mainly about United Healthcare as a payer, but I'll try and generalize to other payers as well. What we do, some payers don't do this, but what we do is we separate consideration of clinical efficacy and effectiveness to determine whether something's eligible for coverage from the issue of cost and cost effectiveness. That we use to figure out how something should be managed. I think the other piece I would highlight is that there's a policy context here that we're all familiar with, which is we have a dilemma, which is medical technology and innovation is valuable and we want to support it, but it also contributes to the high and rising cost of healthcare in the U.S. And I think many people believe that there's too much what's called flat of the curve medicine that has minimal to no incremental clinical value, but contributes to rising costs. So when we also talk about, kind of what's new and what's high value innovation, we have to kind of go through this list. What's new may not be all that new. It may be new, but we don't quite know its clinical utility. We may know its clinical utility, but it could be overused with cost significantly greater than benefit. And we would like to figure out how to support and promote high-value innovation. And we've already heard from Dr. Lauer the issue of disruptive technologies. We think high-value clinical innovation is likely to be disruptive as well. It's likely to be a significant change to what happens in clinical care. So we're on the lookout for that. Joe asked at the outset what would it take and what's in it for us? What's in it for us is very similar to what Alan said. We have really quite compelling questions that we don't, and there are many, that we don't have answers to. These are just kind of the common, typical questions that we have. Does it even work? And how strong is the evidence? Something new. Is it safe? What specific populations would benefit and which would not? How does the proposed procedure, service, drug improve health outcomes? What are all the advantages, harms, and alternatives? And the evidence of effectiveness and safety. I think one of the things that LSTs can bring is the issue of how does it actually work in the real world? We find many times we're trying to extrapolate from very precisely designed RCTs, and we really don't know how it would actually work in typical practice. The other questions we have related to LSTs is the issue of when is an LST the right design versus either a prospective or retrospective observational study. One of the things I was struck with the earlier panel, it seems to me some of the questions that were asked in those studies could also have been addressed by a health system just doing the intervention and then following, seeing what happens. And what are the advantages and disadvantages of a prospective interventional trial versus other approaches? One of the things I'll come back to in a moment is the issue of speed to answer. One of the important parameters, I think, in this whole field is the importance to pick up the pace. We need faster speed to answer, and LSTs may be able to do that if they're simpler to field, if they're faster to collect the data compared to other study designs, and they may offer more generalizable answers to relevant questions. But it seems to me, at least, simplicity can cut both ways. That you really do need, it can be too simple, actually, because you need reliable randomization and truly comparable cohorts if you really want to have good confidence that what you're seeing is the actual effect. The other thing I'd be worried about, I guess, in a simple trial is whether or not all of the relevant outcomes have actually been collected. And because it may be that this sort of tunnel vision, that an LST gives you an answer only looking this way when you really need to kind of look broadly at interactions, at side effects, and so on. I'm struck, for example, that in the studies that we heard earlier that were occurring in actual delivery systems, there was selection going on. Clinicians could choose to exclude certain patients from being approached. Well, I don't quite know how to evaluate that kind of phenomenon in the context of when you get the results. How does it really apply without the strict criteria of a traditional RCT? The other thing I think is we've talked a lot about trials. We haven't really talked that much about the concept of a learning health system. Think about a learning health system that is actually constantly evaluating and improving its own performance. An actual high-performing delivery system may seek to do that and actually not call it research. Might do ongoing randomized trials just because it wants to test doing A versus B. It might randomize sites within, I don't know if Kaiser Permanente has done this, randomized delivery systems within the Northern California system, for example, to see which interventions might work, and never publish that information. Might actually say, we have found it useful, it achieves the aims that Alan mentioned, and it gives us a competitive advantage. So I think that's a set of issues. And it also touches on the issue that was touched on relating to consent. You know, the idea of kind of the boundary between what is quality improvement and what is operations and what is research. And I guess some of you may know better, but my sense is this is not a settled issue. And if it is, please meet me afterwards and tell me what the answer is about where the boundary. The only other thing I'll say about the Affordable Care Act is I think you all know that there's a changing context in the sense PPACA has provisions that expand coverage for clinical trials all the way from phase 1 to phase 4. Cancer and life-threatening conditions. We have had a policy at United Healthcare to support trials for rare, uncommon conditions or to offer coverage when, in fact, the answer is not likely to come anytime soon from a clinical trial. So in terms of policy, I don't think there's a big barrier in terms of the payer side to promote this agenda. It's really much more of the conundrum around getting the answers that we need. And I will conclude with the need to what I call, and taking this from the technologist Alan Kay, we have to create the future by inventing it. And we need greater speed to answer, but not just speed to answer. In a learning health system context, we need to pick up the pace of speed to use. To give an example from Nancy's field, colorectal screening, I believe the current level of performance nationally is around 60–65%, right, of people getting screened who should get screened. Getting that up to 80, 85–90%, that's a really important topic. And it's very gratifying that PCORI has it as part of its mandate to do system-level research to basically try and answer questions such as what is the best way to get that kind of proven service done in the right way. So we need both speed to answer and speed to use, and that also gets to something that's been touched on, the use of clinical registries, which not only is an infrastructure for collecting and analyzing data, but can also be an potentially effective dissemination mechanism to actually rapidly incorporate learning into clinical guidelines, best practices, the kind of alerts that can be in clinical decision support systems. So I guess I would emphasize whatever we need, all the stakeholders need, we need it faster. We need to pick up the pace, both in getting the answers and in getting the answers applied, and we need to work together to promote this effort to promote high-value innovation. So with that, I think it's time for our discussion.